Hi everyone, you are welcome to another MDC question style walkthrough. I'm Dr. Miranda Mawena Wozwame, and I'll be taking you through this past question. As usual, what we do is to answer the question and use the opportunity to go through the topic in detail. So now let's look at the preamble. It says that you are looking at the chest x-ray of Kweku Nyamatu, who is 35 years old and had complained of some discomfort in the left testis for a few weeks now. Now consider the following questions. We are asked to describe what we see and indicates the abnormality. We also asked what the underlying disease is and how we would confirm the diagnosis. The final question asks us to state what the most appropriate treatment is. So let's get into the first question where we are asked to describe what we see and indicates the abnormality. What do we see? We see that this is a chest x-ray, and within the lung fields, we see that there are multiple well circumscribed round lesions in both lung fields. You see that they are round in both the left and right lung fields, and you see that there are varying sizes scattered in both lungs. So these lesions are characteristic for what we call cannonball metastasis, especially given the setting of the question. So this is a chest x-ray showing multiple well circumscribed round radiopaque lesions in both left and right lung fields referred to as cannonball metastasis. Okay, so this is classic. Now, what are cannonball lesions? These are multiple well circumscribed round radiopaque pulmonary lesions of varying sizes found on chest x-rays. So these lesions are found on chest x-rays and can be due to hematogenous spread of malignancies, infections, and autoimmune conditions. So the important point to note is that anytime we see cannonball lesions, we should not only think of malignant spread. We can also think of infections and autoimmune conditions. What are some of the malignancies that present with cannonball metastasis? So renal cell carcinoma, hepatocellular carcinoma, colorectal cancer, prostate cancer, testicular cancer, choriocarcinoma, breast cancer, and then endometrial cancer. So these are not exhaustive. This is not an exhaustive list. There can be other malignancies that can metastasize to the lung and present as cannonball lesions, or what we call cannonball metastasis. Remember, malignancies, by the time we see metastasis, is indicative of poor prognosis. So if you see cannonball lesions or cannonball metastasis, it's indicative of widespread metastasis, not just to the lungs, but to other parts of the body, including the brain, the bone, etc. Okay, and we know that once there's metastasis, usually associated with a poor prognosis. Now, infections can also present as cannonball lesions on the chest x-ray. For example, bacterial infections like tuberculosis, fungal infections like histoplasmosis, and then coccidiomycosis. We can also have parasitic infections like hydatid cysts presenting as cannonball lesions on the chest x-ray. Then autoimmune conditions like sarcoidosis, rheumatoid nodules, granulomatosis with polyangiitis. These also present with cannonball lesions. So once again, the take home is that not every cannonball lesion is as a result of metastasis. They can be due to infections or autoimmune conditions, but more commonly, what we see is from metastasis. So the second question, we are asked to find out what the underlying disease is and how we would confirm the diagnosis. But let's tackle the first part, which asks us to find what the underlying disease is here. And to do that, we need to go back to the question, the preamble, that tells us that we are looking at the chest x-ray of Kweku Nyamatu, who is 35 years old, and that's very important, and had complained of some discomfort in the left testes. Okay, this is classic for a testicular cancer. Usually they experience discomfort in the testes and then the age of the man. Usually testicular cancers present between the ages of 20 to 35 years old. Those are the common age ranges. Okay, so this is very classic. So our answer is that the underlying disease is a metastatic testicular cancer. Okay, now let's talk a bit about testicular tumors. Now, testicular tumors arise from the testes and are usually common between the ages of 20 and 35. So that explains why 35 was a clue in the preamble. Now, what are the kinds of testicular tumors? There are two main types, very simple. We have the germ cell tumors and the non-germ cell tumors. Germ cell tumors and non-germ cell tumors. Now, germ cell tumors are tumors that arise from cells that will eventually differentiate into sperm cells, okay, into spermatozoa. So those are germ cell tumors, and these make up the majority. About 95% of testicular tumors are germ cell tumors, are tumors that arise from cells that will differentiate into spermatozoa. Okay, and the remaining is non-germ cell tumors. Okay, now germ cell tumors are classified into two. We have the seminomes and then the non-seminomes. Okay, so the non-seminomes include embryonal carcinoma, choriocarcinoma, teratoma, and then a yolk sac tumor. So these are the two main groups. We have a seminoma and the non-seminomes. The non-seminomes have different subtypes. We have the embryonal carcinoma, choriocarcinoma, teratoma, and then a yolk sac tumor. Okay, then we come to the non-germ cell tumors, which are in the minority. We can have the Sertoli cell tumor and the Leydig cell tumor. Remember, the Sertoli cells are the cells responsible for providing nutrients for the growing or the differentiating or the maturing sperm cell. Okay, so that's the Sertoli cell. So a Sertoli cell tumor is a tumor arising from the Sertoli cells. Okay, then we have the Leydig cell tumor. What are the Leydig cells? Those are the cells that produce testosterone. Okay, so imagine what happens when you have a Leydig cell tumor. You're going to have excess testosterone being produced. Okay, so these are the two main groups. Germ cell tumors and non-germ cell tumors are the two main groups of testicular tumors. Okay, now seminomes are generally tumors which are said to have very good prognosis because they are slow growing and they take a very long time before they metastasize. They metastasize very late and they have very good response to radiotherapy. So seminomes are considered malignancies which are quite slow growing and have a good prognosis, as opposed to non-seminomes, specifically embryonal carcinoma and choriocarcinomas, which are very, very aggressive tumors. That's why I put it in parentheses. They are very, very aggressive tumors, have very high metastatic potential. They metastasize to the lungs, the brain, etc. Okay, so these are very aggressive tumors, but the most aggressive is the choriocarcinoma. It's very, very aggressive. It metastasizes very, very early. It metastasizes to the lungs very early. Okay, so this case that we are discussing could be a classic case of a choriocarcinoma. In choriocarcinomas, usually you have high levels of beta HCG being produced. Okay, then we also have the teratoma and then the yolk sac tumor, which are commonly found in children. Teratoma, on the other hand, is more benign and is usually malignant when it appears in adults. And the yolk sac tumor is a malignant tumor which is seen in the pre-pubertal stages, usually between the ages of 1 to 4. Also very aggressive and malignant. This is commonly found early in the early years of childhood between 1 to 4 before puberty. Okay. Then we have the non-germ cell tumors. We've spoken about the Sertoli cell tumor, which we said the Sertoli cell produces nutrients or provides nutrients for the growing sperm cell. In the setting of a tumor, it produces a lot of estrogen. Okay. When it comes to the Leydig cell tumor, you have a lot of testosterone being produced. So these are the characteristics associated with these various tumors. All you have to remember is that seminomas have very good prognosis, and then the embryonal carcinoma, choriocarcinoma are very aggressive tumors, with choriocarcinoma being the most aggressive and the one which metastasizes early. Remember that the teratoma and the yolk sac tumors are commonly found in children, the yolk sac tumor being found before prepubertal stages. Okay, now we have seen tumors that arise from the testes. Those are primary tumors because they are coming from the testes. However, you can have instances where tumors metastasize to the testes, and those are called secondary tumors. And it's classic when it comes to non-Hodgkin's lymphoma. Non-Hodgkin's lymphoma is notorious for metastasizing to the testes, particularly the diffuse large B cell subtype. Okay, it's very notorious for metastasizing to the testes. Okay. Now, what are the clinical features? So we saw in the preamble that there was a feeling of discomfort. So they either experience scrotal heaviness or feeling of discomfort. Is usually painless unless it's complicated, and there will be a palpable testicular mass. Remember that some of these tumors produce hormones. For example, we have the Leydig cell tumor producing a lot of testosterone. So patients will present with precocious puberty. And then for tumors like the Sertoli cell tumor, where a lot of estrogen is produced, you can have gynecomastia, ischemia. Okay. And also remember that you can have a lot of beta ACG being produced in excess, especially with the choriocarcinoma. Other features you'll see will be features of metastasis, like we see in this case where we see cannonball metastasis in the lungs. So you can have pulmonary metastasis, so the patient may present with a cough, blood-stained sputum. If it metastasizes to the bone, they may have bone pain, pathological fractures. If it metastasizes to the liver, there will be ascites, abdominal distension, and then there can be lymph adenopathy as well. So these are the clinical features of testicular tumors. Now, let's go to the second aspect of the question. We are asked, how would we confirm the diagnosis of a metastatic testicular cancer? So, how do we investigate? You need to do a scrotal ultrasound, which will show you the presence of the mass, just that it may not be able to accurately tell you that this is either a malignant or a benign tumor, but it will tell you that there is the presence of a testicular tumor. You also need to do serum tumor markers, okay, because these tumors produce these markers. So you have beta ACG, alpha fetoprotein, and LDH being produced. It's very important. They are usually elevated depending on the type of testicular tumor. You would have to do staging because most of these tumors metastasize. So you want to do a chest X-ray or a CT where you will see the cannonball metastasis. You want to do abdominal CT because the testicular tumors are known to metastasize to the retroperitoneum through the lymphatics. So it's important that you do an abdominal CT. You can do a head CT, MRI, and a bone scan. Now, it's important to note that to get the accurate diagnosis, you want to do a histopathological confirmation, but that is only done after you have done a surgery to take out the affected testes. It cannot be done before. You cannot do a biopsy prior to the surgery because you do not want an iatrogenic seeding of the tumor. So it's only done after the surgery is done. So that is why this has highlighted. It is done following a radical inguinal orchidectomy. So these are the ways by which you investigate to confirm a testicular tumor. Pre-operation, before the surgical procedure is done, you need to do a scrotal ultrasound, check for the tumor markers, and do your staging with these investigations. After the surgery, then you do a histopathological confirmation to get the exact tumor type. So we've answered the first question and the second question. Now, what is the most appropriate treatment for a testicular cancer? We saw in the previous question that you needed to do what we call a radical inguinal orchidectomy. This is just a surgical procedure where you need to remove the affected testicle, and not just the testicle, but you need to remove the testicle and the spermatic cord up to the internal inguinal ring. Okay, so that's why it is called a radical inguinal orchidectomy. You're not just doing an orchidectomy, you're also removing the spermatic cord up to the internal inguinal ring. So this is a very radical procedure. And it doesn't end there. Post surgery, you have three options. You will be doing active surveillance, chemotherapy, and radiotherapy. So these are the treatment modalities after the surgery. Now, all these modalities depend on the type of tumor, whether it's a slow growing tumor, whether it's an aggressive tumor. You are also going to look at the stage of the disease and also the prognosis to determine whether you do active surveillance, whether you put the patient on chemo, whether you use radiotherapy. Because some tumors respond better to radiotherapy, others respond better to chemotherapy. And sometimes the disease hasn't progressed that much, so you just want to do what we call active surveillance, where you follow the patient up 3 to 6 monthly for about 5 years to make sure that there is no metastasis or recurrence of the cancer. Okay, so that's the treatment for testicular tumor. So we've answered all three questions. I hope this walkthrough was helpful. So we will see you in the next one.